Today we're going to talk about resuscitative endovascular balloon occlusion of the aorta, or better known as Reboa, to keep it nice, short, and simple. We're going to talk a little bit about what Reboa actually is. We're going to talk about the background and the rationale behind the procedure, as well as the indications versus contraindications, even though this procedure is not widely used in the United States. It has been had several completions across the country, across other countries, the first being in London, which we'll talk about in a little while. We're going to talk specifically about the anatomy, the aortic anatomy, in regards to this procedure and things that we're going to look at externally to help locate where this placement is going to actually be. We're going to watch a short video together and kind of describe the technique for how the Reboa is utilized. So a little bit about traumatic background. It's no question, nothing has changed in the last 20 years. It is still one of the leading causes of death, morbidity, and hospitalizations in ages 1 through 50, with about 130,000 deaths annually, majority of those being secondary to chest and thoracic trauma. 70% are roughly due to motor vehicle collisions and injuries that are associated with the inferior vena cava, superior vena cava, cardiac chamber of the heart, the esophagus, and specifically the aorta have a much higher mortality rate than extremity injuries or head injuries for obvious reasons. That's where most of our vascular system sits. Hemorrhage is the leading cause of preventable death following trauma, and non-compressible hemorrhages accounts for about 85% of those deaths. So what we can't see, we can't stop. And that's kind of where the Reboa starts to come into play. So truncal non-compressible hemorrhages is the leading cause of preventable deaths. Balloon occlusion as a resuscitative adjunct is not new, as I mentioned before, and has been utilized majority of the time inside the hospital, specifically in surgical centers. Much like some of the other procedures, we're just bringing that out to the patient and getting it started much faster and having good results as far as patient saves. So what exactly is the Reboa? So it's a technique that we use in trauma specifically, although it does have some medical usages in the hospital. For trauma, we use it for patients that are bleeding to death by temporarily applying this occlusion inside the aorta, much like a balloon pump does without the inflation and deflation. So specifically we're looking for injuries to the chest, abdomen, or pelvis, and the procedure that we're actually, or the technique that we're actually going to look at here shortly, involves rapidly inserting a flexible catheter into that femoral artery and maneuvering it up through the artery to a specific location, inflating a balloon inside that aorta, which then is going to completely stop blood flow distally from that balloon. So looking at a few indications and contraindications here, because this isn't widely used in the United States, these indications are going to be a little bit generic. The indications that I found here were done by the London Air Medical Company that did the first pre-hospital procedure. But what they had was for indications non-compressible torso hemorrhage, which is the primary reason that we're going to be using this. Patients that are in cardiac arrest, specifically with a PEA, so they do have some sort of cardiac electroactivity on the monitor for less than 10 minutes. So we're going to have some sort of witness arrest here. On top of that cardiac arrest needs to be secondary to a subdiaphragmatic hemorrhage that is or includes the femoral vessels. Severe hypovolemic shock with a systolic blood pressure of less than 70. Patients that are in an agonal state due to non-compressible hemorrhages, so we may be only utilizing the mechanism of injury in this state. Suspected or diagnosed intra-abdominal hemorrhage due to blunt trauma, penetrating torso injuries, or patients with a penetrating injury to the pelvis or groin area with an uncontrolled ability to stop that hemorrhage. For contraindications, we're looking at attention pneumothorax, we're looking at a cardiac tamponade, that same PEA arrest, only greater than 10 minutes, cardiac arrest due to other causes other than a severe subdiaphragmatic trauma, a high clinical or radiological suspicion of a proximal traumatic aortic dissection, patients that are greater than 70 years old, which again is a relative contraindication, and a pre-existing terminal illness or significant comorbidities, again, which is relative and we may not know much of that information. Going back to the first two, the tension pneumothorax and the cardiac tamponade, the reason these are in the setting of the contraindications is because there are other treatments specific to control these two conditions. Obviously with the tension pneumothorax, we're going to needle decompress that's the affected side. If we stop the tension pneumothorax and or the cardiac tamponade, if that's within your scope of practice and they still are showing signs of shock, so they have a multi-system trauma, then they are now going into the indication part of the Reboa. Looking at the anatomy of the aorta, we break it up into 3 different zones, specifically for the purpose of the Reboa. Now keep in mind, similar to much of our anatomy, the aortic length is going to be in direct comparison to the patient's size and height meeting. So we use external figures just like we do with much of our other procedures to help determine where the placement is going to be. So zone 1 we're looking at extends from the origin of the left subclavian artery all the way down to the coiliac artery and trunk. Zone 3 extends distally from the lowest part of the renal artery to the aortic bifurcation. This will make a little bit more sense when we start breaking down how this procedure is done. Zone 2 basically falls into the area in between those. We call this no man's land because this is the area we do not want to place the Reboa. By putting the Reboa here, which we'll talk about in a little while, you risk the chance of not getting the balloon high enough or above that injury. The equipment needed for this, we're not going to go through. This is typically done with a preset, similar to an art line in the emergency department or in the surgery department. So this is all going to come pre-packaged for you so that you don't need to worry about this. Alright, so let's start walking through the procedure here and then we'll watch the video. So the first thing that we're going to do is we're going to palpate for the anatomy and we're going to find that femoral artery in the groin. Obviously, if they have poor circulation, this may be difficult, so much like they do in the hospital, we're going to have to palpate and then we're going to have to start to kind of poke and try to guess a little bit to where this was. I apologize for that, just a little bit of glitch in the electricity. So once we locate where that femoral artery is, we're going to insert the long guide wire into the femoral artery up into the left subclavian. Again, we do this by measuring some external landmarks, so we're going to have to make sure that we can know about how far we're going to be going. So for zone 1, we're going to measure up to the xyphosternum. Zone 2, we're going to measure the umbilicus. And then we're going to use an 18 gauge arterial line once we start placing it. After we insert that guide wire, we're going to replace that arterial line with an introducer sheath. We're going to pass that catheter over the wire through the sheath and inflate that balloon with saline due to trying to avoid some of the gas laws until you feel a change in resistance. Now what we're really looking for here is once we inflate that balloon, we're actually looking for a pretty dramatic rise in the blood pressure. So let's take a quick look at how this works. Alright, so we got our patient. We're going to first use our anatomy. We're going to palpate and find that femoral artery. Now the Reboa has been used for other techniques. The difference with this is it has eliminated some of the risk factors that have been associated with the procedure. So once we locate the femoral artery, we're going to place our guide wire and we're going to run that up to the subclavian artery. Once we have that inserted, we're going to replace our needle with our sheath, and then we're going to advance our actual catheter with the balloon. And typically with this art line, we're going to use a 9 French. Previously they've used something more along the lines of a 12 French, and some of the problems is the guide wire that they used to use didn't do as good of a job of running up through this artery and making some of those turns, and it would kind of cause damage to the art line and leading to more hemorrhage and more required surgeries. So once we have this placed, we're going to inflate the balloon, and like so, we stop the bleed. Now typically, in the pre-hospital setting, this is again done in an emergent setting, so this shouldn't take more than 2 or 3 minutes from beginning to end of the procedure. Now, in 2014, the first pre-hospital Reboa was performed with the Royal London Hospital. They had been working on that for about 2 years, and they had great results. They had a cardiac arrest save pre-hospital. As of now, I don't believe anybody in the United States is actually using this. So to kind of conclude what we've been talking about, Reboa is obviously a very promising procedure for management of a devastating or severe hemorrhage, specifically in the torso. The procedure shouldn't be done to replace any other means, and it should not delay transport of the patient to definitive care. Tension pneumothorax and cardiac tamponades are on the contraindication list because of treatment that needs to be done prior to the insertion of the Reboa. Remember that zone 2 is that small area between zone 1 and zone 3. That is the no-fly zone for replacement. And balloon inflation time and potential with balloon inflation time, the longer this balloon is in place, it does lead to potential for limb ischemia, and it can be a true medical emergency if this is in place for too long. I appreciate taking the time listening to me, and